Good afternoon. I am Norbert Claude Gorin from the Department of Hematology and Cell Therapy at Hôpital Saint-Antoine in Paris. I am the chair also of the EBMT Global Committee. I am pleased and honored to be the moderator for this seminar dedicated to infections in hematology oncology, unfortunately in the COVID era. This is my disclosure. As you can see, but I am essentially pleased to mention that this webinar is supported by an unrestricted educational grant from Air in Space. We have 3 worldwide renowned speakers, and I am pleased they accepted to participate. The first one is Professor Rafael Duarte from Madrid. Rafael is the secretary of EBMT, and he belongs to the Department of Hematology in Madrid. He will speak about infections in Europe. The second speaker is our Chinese colleague, Professor Wang He from Hangzhou, not far from Shanghai. And Professor Wang He is an expert in stem cell transplantation, CAR T cells, but also, in addition, he chaired the special COVID task force who left Hangzhou to go to Wuhan and help his colleagues during the peak of the epidemics. And finally, Professor Arnaud Fontanet from Institut Pasteur and Collège de France will review the status of the COVID epidemic at this moment and possibly the future. Arnaud Fontanet also is a member of the French Scientific Council who advises our president, Emmanuel Macron. And also I wanted to say, please do not leave immediately after the last talk because there is a debate. I will now introduce the specter of infections in my own field, which is hematology and cell therapy. And this slide, already published 10 years ago, shows in transplant patients the risk of infection before, during, and after the transplantation. And as you can see here, we have bacteria at the top, viruses, and fungi. Even though this slide was done 10 years ago, it's still up to date, except that we have to add on the left part of this slide in red, multi-resistant bacteria, and on the right side, insist upon cytomegalovirus, and also more recently about Bika viruses, which popped up with the introduction of haploidentical transplant and high-dose Cytoxan. So I will add one slide regarding bacteria, just to mention that there has been recently some focus on tuberculosis and most of all, latent tuberculosis. And this is a slide which shows the importance of this risk, for instance, here in red, with a prevalence over 50% of the population in South Mexico. Regarding fungal infection, we all know that aspergillosis is not the only one. And I just wanted to find one slide and to show you that we have other risks, such as histoplasmosis. And you will note, of course, at the end of this slide, the mention that mask wearing is protective, as well as HEPA filters, which have been here recently installed in Vellore in India, or even more sophisticated system, such as these ones we and others have in our centers, where in addition to filtering particles like bacteria and fungi, all particles, including also viruses, are now destroyed in an oxygen plasma-built environment. And here we are in China, here also with BioCare rooms, which have switchable positive or negative pressure adjusted to the need of the team treating a specific patient. Now, unfortunately, comes the coronavirus pandemic and the spike protein, as you can see here, all over. I am showing here today the last statistics from the Johns Hopkins University with, as you can see, almost 30 million people so far infected throughout the world, and we probably will reach, unfortunately, soon 1 million of deaths. This slide summarizes, if you go to the last column in red, the number of deaths per million inhabitants per country. and I selected the 9 most unfortunate countries with the highest number of deaths. On this slide, I put the major consequences of the COVID in our transplant departments. The first one is that the use of unrelated donors has become more complex because of the planification, because of the travels, and therefore the number of unrelated transplant has decreased, and as a consequence, the use of haploidentical transplant has further increased. The same story is true for CAR T cells, the use of which has decreased. And finally, for all these reasons, there is an increased use of cryopreservation of stem cells for allogenic transplantation. Transplants that are not urgent are postponed, and I'm thinking essentially of autologous transplantation for multiple myelomas. Overall, there is a considerable drop in activity, and we also know that some cryopreserved stem cell sources in the end will not be used. And last but not least, there are financial consequences as here evaluated again in Velour and presented to us 2 weeks ago at the virtual EBMT meeting in Madrid during the special session of the EBMT Global Committee by Professor Alok Srivastava. And as you can see, any infection, be it bacterial, fungal, or viral, and I don't even think of the recent COVID infection, multiplies the expenses for one transplant by 2. At the end of this seminar, after the 3 speakers, I guess we will have many questions, and I summarized here some of the questions we will have. For instance, mutation, do they occur? We know the answer is yes, but does it really matter? This will be one question. A second question will be, will we really get soon directly antiviral new drugs? We do not very often hear of this, and aside from remdesivir, we don't know. And the third question is, what about vaccines? We have almost too many vaccines, so probably one is safer than another one, and which one? So just to illustrate the mutation, we have here the first strain of a virus with a G614 mutation emerging in Europe in blue, as you can see, since April. So it started with D614 and it's now G614. Is it important? About new drugs, I just selected the first one I saw by pure chance about a drug we don't know very well, which is called opaganib, and which apparently is very effective and more effective than remdesivir, or synergizing with remdesivir in destroying the virus. And finally, this slide among very many from the New England Journal of Medicine in July, showing important efficacy with mRNA vaccines. So finished with my introduction, and I would like now to leave the screen to our first invited speaker, Professor Rafael Duarte from Madrid, Spain, and see you at the end of this session for the debate. Thank you.
Hello, everyone, dear friends, dear colleagues. I'd like to thank Professor Goran for the opportunity to be here today and to discuss all together about the infectious challenges that we're facing in the era of COVID and give it our own perspective from EBMT and from Europe. I think that it is perhaps a diagram like this that refers to allogenic transplant recipients, but we've all learned to use as a diagram of risk of infection, of the different risk factors that our patients face, and also what are the high incidence major infections that they suffer. And even though this is quite specific to allogenic transplantation, acute and chronic GVHD only appears there, many other factors, central catheter, mucositis, neutropenia, impaired cellular and humoral immunity with new drugs also affect many other hematological patients, hemonc patients. The arrival of COVID-19 has clearly brought additional risks to these patients, not only in terms of the infection itself, but also in how the management that would be enforced to do in these patients is also changing the risk for other infections. I'll try to start with general principles, because overall, we can all safely say that general principles should remain. I'll start with prevention. I think that this is very. I'll go quick through this. The general guidelines for prevention of infections need to still be there. The isolation procedures are also still applicable in our patients, and with those come the specific recommendations that we all follow for ventilation, for single room occupancy, for antimicrobial stewardship, and for all of that. The reality is that, as you know, the pressure on the health system and the pressure on the hospital has made that sometimes we have to manage hematology patients in different conditions. For instance, in my hospital here in Spain, at the big initial outbreak a few months ago, even though we kept the hematology ward for transplants functioning the whole time, a lot of the patients that were admitted with COVID went actually to COVID wards, even though part of the hematology team was actually there to look after this. So we kept the expertise of the team, even though in a different location. Of course, these general principles apply to all the infections, bacterial infections, and our approaches to escalation or de-escalation management based off our epidemiology, based on the resistance that we have, and based on the advantages and disadvantages in terms of overuse of antibiotics and the potential antibiotic pressure to induce resistance, all those don't change significantly. These are guidelines for treatment of fungal infections, and those also remain pretty much the same in this context. And I'm focusing initially on this treatment because I think that one of the points I want to make is in this anti-infective management is the priority that we need to all bring in prevention and in prophylaxis in this patient. But treatment as such wouldn't really change dramatically. Viral infections, and of all those, the major infection that our patients face is CMV infection. And here I've selected from the SCL7 guidelines these recommendations for antiviral prophylaxis. The rest of them, even within SCL, have not changed dramatically, but the arrival of letermovir has really made a difference in these patients. And all these prophylaxis clearly makes a difference in duration of hospitalization and also on the requirement to bring patients in and admit them to hospital if they do have a CMV reactivation. So in the current situation of a COVID pandemic, these should be taken as a priority. Recommendations as well for vaccinations. And I think that these are also very relevant. We have them very close to our hearts now because ESIL has just updated them very recently. All these are tables taken from the EVMT handbook, and I want to highlight perhaps only influenza. Influenza is clearly very important, but it's going to be particularly important in this period, and we all know that there might be some potential cross-reactivity that might make some vaccinated patients a bit less susceptible to severe forms of disease. But more important than that, what would be really difficult to manage is the overlap of a COVID pandemic with also a flu season in which we don't take as much measures as we can to prevent influenza in our patients. All the others don't change very dramatically, and you know all these recommendations. Haemophilus, diphtheria, all these recommendations do not change dramatically in these patients. I think it's important to consider that there's not a unique vaccine schedule that we can apply to all. Clearly, the benefits are both for the society to avoid at a population level creating a host of immunity, but also there's an individual interest for each of our patients. And as the COVID vaccines are under development, and they come with different mechanisms and different ways of action, we'll have to see when we have the results how our patients are approach the possibility of receiving COVID vaccination. That's something that will develop in the next few months. What is the impact in this very brief summary of anti-infective management and the general guidelines? What is the impact that COVID is having, and what is the impact that we've experienced? Clearly, the impact goes not only in infection, but much beyond. There's an unprecedented pressure on healthcare systems, not only at hospitals, but also primary care and ICUs. There's changes in the allocation of resources. There's disruption of the transplant teams, not only physicians that get infected, but also quarantined, and then physicians that are taken away from teams to be able to look after the COVID patients. I told you a little before about how we organized that, and many of my team, the members of my team, actually had to look after COVID patients, and one of the ways we arranged it is that hematology patients with COVID were specifically looked after these physicians, these team members. There's clearly issues about unrelated donor procurement, not only assessment, but also collection and transportation. And it is very important as well knowing how COVID infection itself has had an impact as an infectious complication in these patients. And all this under the uncertainty that we've had about the management of patients that are already immunosuppressed and who are at risk for infections, and for whom many of the treatments that we've been trying during the pandemic, we didn't have a lot of evidence, a lot of understanding how they would go. There's been clear recommendations. I think that is a tribute to everyone in different societies who made the effort of very rapidly, from a scientific society, provide the community with recommendations for this challenge, how managing these patients, in particular transplant recipients and CAR immunotherapy, CAR T-cell therapy patients have been addressed in some guidelines. Also, and of course, with the higher experience of having experienced this pandemic earlier, a lot of this information is coming from China. Professor He Huang is one of the leading authors, along with many other international and Chinese colleagues, of these specific management strategies and challenges for CAR-T. The reality, though, is that even though we've had all this information, granularity of information about infective complications other than COVID itself is still small. It's still something that we have to collect, and there's repositories and registries where we're collecting this data, including EBMT, and hopefully we'll learn soon. I want to give a general concept coming to this point, and is that beyond the specific microorganism, the management of infections, opportunistic infection in hematology oncology patients, really can rely on a few tools. Can rely on prophylaxis, as long as it's effective and safe. It relies as well on diagnostic tools, and we know that is something that is obviously very important, that has been developed and is the way to treat more accurately these patients, and also on the availability of treatments. I think that all these three parts of the equation of tools that we can use to manage these patients in the context of a pandemic, on the pressure over hospital wards and beds, clearly lead us all to give a higher importance, higher relevance to the role of prophylaxis. And this applies to many different infections. I'd like to highlight two. Fungal infections, clearly. Fungal infections are not only prevalent, and the rates are in excess of 10, 12, 15% in hem-onc high-risk patients, primarily acute leukemia, myelodysplastic syndromes treating with high intensive chemotherapy for induction, and also allogeneic transplant recipients, in particular those with graft versus host disease. But there are also other patients that still would be benefit from some prophylaxis, even if not necessarily only for mold cover, but high-risk patients need mold and yeast cover for prophylaxis. And at the same time, during a long time, we've sort of faced that duality of prophylaxis and diagnostics as something that it was not easy to reconcile, as prophylaxis reduces the incidence of infection and therefore the performance of the test. At the same time, the tests don't work so well in patients that are receiving some drugs and prophylaxis. So I think that we've made an effort, and I'll summarize this without additional data or slides. And there's a couple of studies. We published the first study in CID in 2014 showing that patients with effective prophylaxis with posaconazole could still be monitored with galactamana, not necessarily in the screening period as surveillance, but yes, in diagnostics still remain useful for diagnostics. And this was validated externally later from another group here in Madrid, from Gregorio Marañón, using a different drug for prophylaxis with caspofungin. And they also showed that we can reconcile effective prophylaxis with diagnosis to treat and benefit patients. This becomes a priority now, even in centers that traditionally might not have used prophylaxis as a standard of care. Also, in cytomegalovirus. Cytomegalovirus, we've treated for decades. We've learned to use diagnostic tests we have, and at the same time, the drugs that we have available to treat. We know about the side effects, and we know that beyond all these strategies, after more than 2 decades of a preemptive therapy strategy based on diagnostic tests, patients at risk for cytomegalovirus and those that reactivate do worse than patients that do not reactivate cytomegalovirus that are not at risk, and a difference of around 10 to 15% in overall survival. Clearly, the arrival of letermovir has made a difference on this, and improves outcome, reduces all-cause mortality, and reduces dramatically the incidence of infection, which also associates with reduction of the days of admission and reduction of the hospital stay and need for readmission in subsequent recurrent CMV reactivation. So I cannot stress enough the role of prophylaxis in this context of a COVID pandemic. What is the impact that we see? I'm going to share with you some data. This is activity from the Spanish Transplant Organization, and you can see that in the months of the bulk of the pandemic, clearly comparing 2019 and 2020, the unrelated donor transplant activity reduced dramatically. Not only that, we are seeing as well a very sharp reduction in the number of requests for CAR T therapy. CAR T therapy is much more advanced, has been developed much better in China. It has been here in Spain, where for the most time, and largely in Europe, where for the most part, it's been recently, since just a few months, year ago, that we started using CAR T cells, and that started being available to our patients. But nevertheless, even though you see, a progressive increase in the use, you can easily see that when in the month of March this year, the request, and part of the committee of the Ministry of Health that evaluates all the requests that still at this point needs to be centrally evaluated. One of the members of that committee, and we were, for the past months, we were very busy evaluating all these requests quite often, because it's got to be at least 3 of us that do this evaluation. And however, right now there's very few, hardly any CAR T requests, but something that we also have to make up for in the second wave of the pandemic. And outcomes. I'm gonna share with you a little summary of data from a couple of studies. This is a study from the Spanish transplant group that includes not only transplant, but also non-transplant hem-onc patients, 41 centers, both pediatric and adult patients, is retrospective analysis. The primary objective was to describe the clinical characteristics of these patients, try to figure out how is it that they look like, and also looking at some analysis of mortality and potential risk factors that associate with mortality or with the potential benefit from the treatments that we were using in all COVID patients, hem-onc and others. And this is the summary. These are the outcomes, and these are the patients that we have. There's 244 non-transplant hem-onc recipients, and then autologous and allogeneic transplantations. Clearly, there's demographics that vary between type of patient, and that just probably defines how candidates for autologous and allogeneic transplantation and some are somewhat selected based on these demographic factors, so it won't take much time there. And these are the factors that really influence results. The independent risk factors for having a severe form of COVID in hem-onc patients are hypertension, lymphopenia, and CRP. And we don't see really differences in clinical laboratory characteristics between the transplanted and the non-transplanted with regards to the severity and the presentation or the duration of hospital admission with COVID-19. More results from the Spanish study. There were differences between the transplant recipient and non-transplant recipients in terms of antiviral therapy and the use of corticosteroids, which is greater in transplant recipients than it has been in the general population of other hem-onc patients, and also the recovery from COVID as a result probably of the deeper immunosuppression that these patients have. Conversely to what one would have perhaps anticipated, it was not a poorer outcome. The overall had, if anything, a lower overall mortality in transplant recipients compared to the others. As you saw, the demographics were different. There were more comorbidities in the other patients, but nevertheless, being a transplant recipient doesn't put you automatically in a far worse risk of this infection. These are the curves, and as you can see, the based on COVID stage and based on risk factor, having 0 to 1, 2 or more than 2, older age, disease status, neutropenia, and high CRP are the main drivers of mortality in hem-onc patients treated with COVID. Clearly, there's still things that we are missing in terms of the total understanding of the factors that influence this outcome. And we are engaging the Spanish study with the high incidence that we had with EBMT in a combined analysis with large environment to explore all these. Preliminary data from this combined analysis have been presented by Per Lindemann at Virtual EBMT 2020 just a few days ago, and you've got their curves of survival by type of transplant, allogeneic and autologous, and you've got there the B-log ranks not statistically significant, and this is not with these numbers, and same thing, survival depending on age, children and adults. When we looked into these factors to see the factors that really associate with outcome, perhaps the most striking difference is that is age at COVID and performance status that makes a real difference beyond other factors. That probably also associated with the makes sense in the findings that we had at the Spanish study of the out transplant recipients not doing worse than the hem-onc patients that overall have a higher age as well. So I think that I'll leave it with some lessons for the future and with two small comments. We gotta try and maintain the activity. It doesn't look like this is it's going to go anytime soon. So we got to keep the activity of transplantation and cellular therapy in these patients. And I think that we need to highlight that there's a need for the strict measures of infectious disease control for prevention in inpatients and outpatients to be done. That goes along with telemedicine, with many other strategies. And also, I want to highlight the fact that anti-infective strategies should be particularly proactive to prevent infection complications with the use of primary prophylaxis. Prevention is paramount in these circumstances. And I'll leave you just with a few images in the last couple of minutes. You know that we had this Congress in EBMT Congress in planned for Madrid this year in March. IFEMA is the third largest convention center in the world for international conferences. This was planned for March this year. This is what we used to do. These are the meetings where we all made the interaction that we normally had. And however, we ended up having to transform that to a virtual meeting, and it's been very successful. We have over 6,700 participants. The sessions have had more participation through the virtual tool that we could ever have imagined in an on-site physical meeting, but clearly also have come with some limitations. This is the map of IFEMA, and this Hall 9 and the North Convention Center is what we were going to use for our Congress. And this is Hall 9 in March, right that same weekend that we were going to start the Congress. And what we were building there, unfortunately, were not the industry stands for education and for communication. It was beds for this large hospital that we set up, second to the one in Wuhan, the largest in the world, after one in Wuhan here in Madrid. And we also decided that nevertheless we're still planning for a hybrid meeting. We'll have to see in March next year. So hopefully, if everything goes well, depending on the pandemic during this winter, we'll hopefully have at least an on-site and also access virtual, depending on the circumstance for everyone to be able to tailor the meeting to their needs. And finish with my last slide, which brings a discussion that I think also needs to be optimistic. We're suffering from this infection, or patients are suffering from this infection, and hemo patients suffering from this, but also hematology, oncology. Hematology is also fighting back the disease. And I'm going to leave you here only the image, and I encourage you, if you didn't have a chance, to go back to our website, to the EBMT Virtual 2020 website, and listen how endothelial treatment and dysfunction, how mesenchymal stromal cells, how convalescent plasma, how many of the antibodies, monoclonal antibodies that we use in the treatment of our patients are also potentially of use in COVID. Thank you very much again for the invitation, and I'll be looking forward to answering questions and to discuss at the end. Thank you again.
Good afternoon, dear Professor Goring and the colleagues. It's my pleasure attending this meeting. I'd like to talk about the prevention and the treatment of the major infectious disease in hematology and oncology patients in the COVID-19 era. I, Dr. Huang, come from the Zhejiang University School of Medicine, First Affiliate Hospital. So I'd like to talk of the three the subtopic. One is the pandemic of the COVID-19 in China and the influence of the hematological malignancies. We all know the COVID-19 pandemic, and first in China, February, and lasted about 3 months. So here is the total confirmed case, and we can see here is from the February and January, February, and until about the April, and stop here, the case not increased. The very new confirmed case we can see here is the March and February is very high, and in here is a member of China, and our the Zhejiang province also the heaven hit by the pandemic. So I'm sorry, we can see here the pandemic globally. The COVID-19 is very spread very fast, and here is the confirmed diagnosis. So Americans and another European countries, another Africa, is many countries have the from the collaborate the COVID-19. So how about the hematological disease during the COVID-19 pandemic? Here is the publication in China, the Wuhan hospital, and the total is 21 hematological disease patients suffer from the COVID-19. And the analysis comparison of the overall survival in patients with hematological malignancies patients and by the COVID-19. And under the intensive chemotherapy and undergoing intensive chemotherapy or immunosuppression, and we can see here the patients, if the subject receive the chemotherapy or immunosuppression treatment, the survival is very, very poor. Another publication also analysis the influence of the COVID-19 on the hematological disease. We can see here that in patients with the uncontrolled hematological malignancies and 10 of the COVID-19, the mortality was 33%. Is the higher is 63% versus the control is 80%. So in patients with uncontrolled hematological disease and the 10 of the COVID-19, the mortality was higher, 44. The transplantation patients' mortality is also high. The influence of the COVID-19 hematological, the conclusion is COVID-19 was severe in patients with hematological malignancies, and their survival was strongly correlated with the COVID-19 stage, and the patient and the disease-related factor, just like the old aging, disease status, performer status, immunosituations, and the systemic inflammation. The prolonged incubation period, the complied laboratory patents, and the confirmed radiological finding might eventually lead to the misdiagnosis of the COVID-19. And the hematological cancer treatment during this critical period should be adjusted on the case-by-case basis. The importance of the home-based oral chemotherapy or reduced clinic-based simplified chemotherapy regimens with the higher therapeutic efficacy and low toxicity for patients with hematological malignancies. So second, I'd like to talk about the management of hematological malignancies in the COVID-19 era. And here is the special characteristic of the hematological malignancies patients. Here is the publication by the Wuhan hospital. Such the patients is suffer from the COVID-19 in the hematological malignancies. We can see here the characteristic intervention by report COVID-19 case. The fevers, paroxysmal dry coughs, and the productive coughs, and I think the respiratory resistance manifestation is very important. And for the CT scan, we should the differential diagnosis for the another virus infections. Here is a special characteristic of the hematological malignant patients. This patient is 51 years old, was confirmed with COVID-19. We can see here the CT scan shows the changing. And here is another patient is the CMV pneumonia, and 26 years old male after allogenic stem cell transplantation. We can see here the CT scan shows the different, and it is more solid in the COVID-19 patients. The CT scan changing. A special characterization of the hematological malignant patients. The rest common and more delayed clinical features such as mild fever and the no productive cough. The laboratory results of the coexisting hematological malignancies might not quite consistent with or even contradict with the reported COVID-19 specific patterns. Due to the function defect of the T cell or the monocytic macrophage system, the imaging results of the hematological malignancy individual won't divide from the typical presentation. The incubation period of the COVID-19 and the disease course of the COVID-19 could be prolonged in the background of the hematological malignant disease. The treatment strategy to track the coexistence of the COVID-19 and the hematological malignancies should be taken into the consideration with the adjusted chemotherapy dose, adjusted transplantation stage, adjusted chemotherapy antigen receptor regions, and the enhanced supportive strategies. In our sentence, we have the published articles, and we provide the protocol and the flow of the algorithm of the hospital admission procedure of the hematological malignancies patients during the COVID-19 pandemic. And such the patients in our hospital, and first we'd like to confirm is evaluated the high risk area or the low risk area. And for the high risk area, we should first check the clinical symptoms. If the positive, we'd like to blood test, just the CT scan, and the antigen, the COVID-19, and the MDT discussion, and another antibody, COVID-19 antibody detect. For such patients with the evaluation of the tumor burden, and then we'd like to divide the new diagnosis, relapse, and refractory, and remissions, and we have the different treatment. And for such the history of the exposure of the clinical symptoms, and we'd like to check the chest CT scan, blood, and the antigens, and we'd like to divide it into different wards. Here is also a summary, the overview of the management strategies of the hematological malignant patients during the COVID-19 pandemic. So, and first, the identification of the hematological malignancies patients are typical COVID-19 clinical manifestation, just like cough, fever, dyspnea of the even in the chest, tightness, the longer incubation period, and another is should be the diagnosis and the differential diagnosis. We should perform some of the tests just like the antigens antibody. And then the adjusted treatment regimens for the hematological cancer. For such patient, the special time, maybe the oral and the take-home therapies are preferred. And the simplified regimen for the reduce the hospitalization and determine deferment of the treatment for the stable and the no high-risk blood cancer follow-up. And the hospital management for the hematological patients, if such the patients and in our hospital improve the emergency response for the hematological oncology ward, remote medical guidance and therapies, and the tele report of the suspended and confirm the patients. And we'd like to enhance our education, the personal hygiene and the preventive medicines measures, just like the wearing face mask and the proper hand wash and the social distance is very important. And another is the quarantine and isolation, the fixed caregivers and the adequate nutrition. And finally, the intervention and the management of the COVID-19 infection. If the patient is diagnosed from the COVID-19, and we have to the special ward for the special treatment. And for the transplantation ward, because already perform the many cases every year the transplantation, how about the transplantation ward in the COVID-19 era? So the optimization of the screen and admission process. And in our hospital, there is the fever clinic, and first the independent area, standardized procedures, 3 zone and the 3 passengers, and preview the changing patients classification independent functional section, and the patient management. If all the patients should be wear the mask and minimize the staging time. And the pre-transplantation, we would like to manage the hematopoietic stem cell transplantation. It's a high community prevalence area, and we should the emergency transplantation and screen for the COVID-19 and the chest CT scan and the genomic sequence and the detection of the serum antibody. And if negative, the positive, and we move to the special wall, and the negative we will continue go on for transplantation. For the transplantation and the unrelated donors, sometimes is very restricted because this is shaping and the cryopreservation, and we'd like to cryopreservation in advance of the transplantation before the condition regimen. And an alternative haploidentical, the backup, and corrected and cryopreserved autologous stem cell transplantation as a backup. The related donor also we suggest the patients have the backup donor and autologous and the GCS and the flexiform based the mobilization regimen is preferred. And the post-transplantation, the education patient and all family members on the instruction regarding isolation and preventive measures. The self-isolation at home and minimize the number of the family members to visit, and the telemedicine based or online visiting, and explore ways to the patients have the good blood test away from the busy area in hospital, the isolation the patients. The hematopoietic stem cell transplantation in all the BMT, we just say the China, the peak pandemic COVID-19, and from the February to the April, and this time, and we also performed the 49 patients received the transplantation, including the 39 haplotransplantation, and 4 is identical siblings, and 1 is the unrelated donors, and 5 the autologous stem cell transplantation. And in China cities, another cities was hit faced the risk of the explosive spread of the COVID-19. And so we will have such the recommendation, the protocol to avoid the risk of the pandemic. And for the another the platform is CAR-T treatment, because all the perform the CAR-T many cases. So how about the CAR-T patients, the COVID-19 era? The clinical characteristic of the CAR-T therapies candidates, because such the patients and the always aggressive or progressive disease, and the CAR-T therapies might be the sole options for those with high-risk hematological malignancies. So we should evaluate the pandemic risk and how about the treat patients. And the rapid disease progressions require the temporary manufacturers and the infusion of the CAR-T cell into these patients. Hence, weighing the risk and the benefit of the CAR-T therapies and improving the practical efficiencies of the treatment during this critical period of utmost importance. So here we also have to provide protocols. How about the admission procedures for CAR-T treatment during the COVID-19 pandemic? And we suggest the evaluation of the pandemic prevalence and the high community prevalence and the low community prevalence. And if the high, we at first the wait and watch and risk 14 days and the screen and the differential diagnosis, RT-PCRs, longer CT scan, and the serial IgG/IgM detection and the expert consulting. And if the negative and the weight differential the diagnosis of the COVID-19, the patients receive the CAR-T treatment and the discharge instruction, and we will suggest the patients wearing the face mask and wash hand, social distancing, minimizing the visitors, avoiding the crowd places. Follow-up, we suggest the patients online follow-up with the 24 hours and any time if necessary. The outpatient follow-up in the local hospital, such as the community hospital, IACH, replacement injection. So for the CAR-T cell donors, also we should be screened the COVID-19. And for the symptomatic donors, we will evaluate the epidemic histories and the evaluation of the clinical manifestation. We suggest that the donor receives such as a screen, the RT-PCR and the lung CT scan, and the serious IgG/IgM detection and expert consolidation. And after such a screen, the donor can be the eligible donors. Here is published as BMT, and also suggests the CAR T cell resources and the potential disruptor during the pandemic, maybe the apheresis and the cell processing and the shipping and the logistic, manufacturing, hospital capacities, ICU capacities, blood bank, laboratory tests and radiation, pathology, caregivers, and housing. So such all factors should be considered by the physicians. And here is all for the CAR T treatment strategy, and in the summary of the representative regions from China mainland, from the January to the March this year. And here is all hospital. We can see here is perform the CAR T treatment patients. Here is the Tongji Hospital, and another is the Tianjin Hospital, another hospital. And from this, we can see here is the Wuhan. Wuhan, we think, is the storm center, the pandemic center, and the virus is CAR T center. And we can see here the number changing. Here is from the January to March and to 2019. And here is from July to the September 2019. But here is this year, the first 3 months, and from January to the March is the drop down the case. So strategy in infection disease during the COVID-19 pandemic, the patients with cancer with the fever or respiratory syndrome consider causes in addition to the COVID-19, including other infection and the therapies related to pneumonitis. Clinicians should be alert on the possibility of the alternative or second infection, and the vaccination against the influenza, and hence to the another recommendation measures to reduce the infection risk. Patients with hematological oncology disease develop the symptom should be minimized, treated related immune suppression to reduce the risk of the drug-linked reaction. Finally, we'd like to talk the clinical trial in the CIS induced by the CAR T and the COVID-19. We all know the CAR T and the COVID-19 all induce the patients suffer from the cytokine release syndrome. The cytokine release is potentially life-threatening symptoms caused by the viral infection, autoimmune disease, and the administration of the antibody-based therapies. And the cytokine storm symptoms and the pathological and the potential precision therapies here is the list. And the CIS induced the CAR T treatment is induced by the direct target cell releases with the consecutive release of the cytokine. This cytokine trigger chain reactions due to the activation of the innate immune cell like the macrophage and the endothelial cells with further cytokine release syndrome. So we'd like to ask a question, some difference or similarity between the CIS induced by CAR T or the COVID-19. And we analysis our hospital, and the COVID-19 group is 40 patients, and the CAR T is 41 patients from all the hospital, and the treated such as grade 3 or more, the severe CIS. And we can see here one is group is COVID-19 group, is a CAR T group. And there are some difference. Here is the maximum temperature, and the CAR T temperature is higher, and the cough and the COVID-19 is higher. And another is just like breathing disease, breathing difficulties is higher in COVID-19. and the hypotension and hypoxemia also. And we can see here is the CIS induced the CAR-T and COVID-19. And here is incidence of the clinical symptoms and COVID-19, CAR-T, and the expectation. Here is the CAR, expectation, dyspnea, hypoxemia, and the hypotension. There are some difference. And COVID-19 and CAR-T, there is the maximum temperature, and here is we can see the CAR-T patients is higher, and the duration of the fever is also. And the peak serum level of the cytokine, procalcitonin, and the C-reactive proteins, D-dimers, and the ferritins, and with the grade 3 or 4 CIS in COVID-19 group and the CAR-T group. And the data shows described as a median. So we can see here is a CAR-T, and almost is higher. CAR-T is interleukin 2, interleukin 6, interleukin 10, and also interferon. And here is just here the interferon alpha is the COVID-19 is higher than the CAR-T, and another is almost is higher than the CAR-T group is more higher than the COVID-19 group. The correction between the virus load and the tumor burdens and the cytokine levels with the CIS in COVID-19 group and the CAR-T group, and the correlation and the linear regressions was used for the statistic analysis. We can see here is very clear the correlation between the virus burden load and the leukemia burden. A complication in patients with the severe the CIS, we can see here the COVID-19 and CAR-T, and there are some respiratory failure. There are some difference. COVID-19 is higher, and here is the transfer for the ICU also higher in the COVID-19 group. So inflammatory response in the CIS caused of COVID-19 and the CAR-T cell therapy with similar, but the difference intensity. Cytokine like interleukin 6, interleukin 10, interleukin 2, interferon alpha, interferon gamma experienced available increased to group, with the interferon alpha exhibited significantly higher levels in the COVID-19 group. The diagnosis and the treatment experience of the CIS in CAR-T cell therapies may provide great impetus for the CIS. Interferon alpha inhibitors and the CIS COVID-19 specific CAR-T therapies may be feasible therapeutic with Aquaria's further investigation and clinical experience. So I think the COVID-19, the pandemic, and the CAR-T, and we have some similar symptoms, but I think the mechanism is a total difference. So in futures, we'd like to further study such as the CAR-T and the pandemic. How about the CIS, and how about use some methods in intervention? Thank you very much. Thank you for your attention.
So hello everybody, it's my pleasure to give this lecture on the COVID-19 pandemic. The title I use is Season 2, meaning that for many countries we have had our first wave, and now I would want to share with you my views on what we have to expect for the coming months. I know some countries are still in the middle of the first wave, but basically I think that this talk will address many different issues that will be relevant to all of you watching this video. So my name is Arnaud Fontanet. I am a professor at Institut Pasteur, the head of the Department of Global Health. I'm also teaching public health at the Conservatoire National des Arts et Métiers, and I was also making a course on pandemics at the Collège de France last year. And finally, I am a member of the Scientific Council advising the French government on the COVID-19 crisis, and I have no conflict of interest to declare. I will start by focusing on the situation on France. As you can see here, this slide is showing you estimates made by mathematical models of the proportion of people that have been infected at the end of the first wave in France. We are on May 11th. And as you can see here, the estimate is that about 4.4% of the population of France has been infected between February and April, to make it simple. And that epidemic began in the eastern part of France, as well as in a cluster in the northern part of France. And this explains why these regions of France have been more severely hit. We believe that about 10% of people have been infected there, whereas about 5% of people have been infected in the middle of France and only 3% in the western part, which is called Bretagne. The R0, the basic reproductive number, which tells you for each patient how many people will get infected, was estimated at 3 at the beginning of the pandemic, or in the epidemic for France. This is in the absence of control measures, you know, when the virus was circulating freely in France because people were not aware yet that it had arrived. And mathematical modeling tells us that the proportion of people that would need to be immunized for the virus to stop to circulate spontaneously, freely, with an R0 estimated at 3, should be 1 minus 1 over R0, which in this case will make 67%. What we are saying here is that it will need 67% of the population of France to be infected with the new SARS coronavirus before the epidemic stops spontaneously. The first question I'm going to address is, as you may know, France, like many other countries, had to put in place a lockdown. That happened for us on March 17. The first 2 weeks of March was a time where the epidemic was raging in France, and the Scientific Council, to which I belong, advised the government when we met for the first time on March 12 to move quickly to a lockdown, which was put in place on March 17, as intensive care units in France were just completely overwhelmed with patients arriving with this very severe lung inflammation. And in the eastern part of France and the northern part of France, the intensive care units could no longer cope with those patients arriving in very large numbers. So the decision was made to put a lockdown on France. But the difficult one was, should it be restricted to the parts which were most affected by the epidemic, I mean the eastern part of France and the northern part of France, or should it be done nationally? And of course, you realize that the social and economic cost of a lockdown is huge. So that decision was not an easy one to take at that time. We finally decided to go for a national lockdown, and retrospectively, when we got the data completely consolidated, we realized that we were probably right. On this slide, you can see the 13 regions of France, and you have here the epidemic curve based on the admission to hospital. Here is the threshold of 1 admission per 100,000 inhabitants, where we would consider that the epidemic has gone wild when you reach that threshold, you know, and that it would be extremely difficult to stop it with typical control measures, particularly at a time where in France we did not have enough tests, we did not have enough masks. So as you can see here, all the region of France end up reaching that threshold before peaking. The first one to reach it was the Grand Est, which is the eastern part of France, and you can see that that was around the 10th of March, and that's where the epidemic curve was worst. This is northern part of France, and Ile-de-France is Paris and its region, and you can see also that this threshold was met quite early. The region of France which reached the threshold the latest was Bretagne, in the western part of France, and you can see that that was around the 23rd of March. The lockdown had been put in place here, as you can see with this line, which means this is 17th of March, and it is the time the lockdown was put in place. So the first message is, wherever you were in France, at some point before the peak of the admissions of hospitals, the epidemic had reached a stage where it would have been unstoppable, and this is why it has been important that the lockdown was put in place. The second interesting message of these slides is that regardless of whether your epidemic started very early or quite late, like in Bretagne, the time when the admissions peaked was about the same. It was, as you can read here, 28th of March is the time of the peak, plus or minus 1 or 2 days if you want, if you look at the different regions. And that is exactly 11 days after the lockdown was put in place. And 11 days is the time between infection and hospitalizations for the people who do the severe form of disease. What we are seeing here is that it is a lockdown and not anything else, magic, that stops the admissions to hospitals. And therefore, it has been truly efficient. And whether your epidemic has started very early, like the eastern part of France, or very late, like Bretagne, it's exactly at the same time that it will stop. And that is the effect of the lockdown, and it was important that we could document that. Now, when we look at Europe, and different surveys which have been performed using antibody tests, what was the proportion of population that has been infected? We saw that for France, mathematical modeling was pointing at 4.4%. Spain, which was also very severely hit by the epidemic, the threshold, well, the proportion of the population infected was 5%. Geneva, but this is just the city of Geneva, not the entire Switzerland, was 10%. And this is what we have seen in France, in Paris, in the big cities of the eastern part of France, we have about 10% of people infected. Sweden, 7%, but that was in April. You know that since the epidemic has continued to progress in Sweden. And Finland, which has been quite spared by the epidemic, is at a lower level, around 2%. And here are the figures for the blood donors. Now, there are some questions. Do we truly need to get this 66 or 67% of the population immunized before we reach herd immunity, or could it happen earlier? And some people have been questioning that and saying, well, we find this figure far too large. As you could see from the previous slide, we are talking about 5 to 10% of population that has been infected. It means we would have done only 20% of the road to herd immunity. This is really sad news. So there are some issues like, would seasonal coronavirus, for instance, protect us? And you know that this new coronavirus is somewhere between seasonal coronavirus that gives flu, or the SARS or the MERS that gave severe lung disease when it comes to clinical manifestations. And some people felt like there is a very large proportion of individuals who got seasonal coronavirus in the world, and maybe that gives you some protection. And there are some work on T-cell immunity suggesting that. There are some people also who have been measuring the T-cell reactivity among the contacts of the patients. The contacts did not get antibodies, but they do show some T-cell reactivity. Does it protect? And then there are issues of this theory of 2/3 of the population has to be immunized before the virus stops to circulate spontaneously is based on simple mathematical models where people just mix what we say homogeneously, and there is not sort of some people that get very socially connected and would be the first to be infected and then would themselves infect other people because they are socially connected, and other people that would be very excluded from society, for instance. And if that happens, then indeed that figures should be lower. At the end of the day, when it comes to this heterogeneity, it may have an impact, but probably not as large as some of it expected. And finally, the children, and I will come back to that. It seems that children are less likely to become infected, and also that they would be less likely to infect others, particularly the children less than 10 years of age. What is it about all that? I'm going to touch upon some of those points in the next couple of slides and then summarize a little bit our thoughts about this. We had actually in France a natural experience of infection in a place where people thought of mixed quite homogeneously, which was an aircraft carrier, Charles de Gaulle. And there, the sailors were on board on 15th of March. They waited 2 weeks and were very careful trying to find out is the disease on the ship or not. And then after 2 weeks, there were no declared cases, and they felt like, that's fine. We did not embark with the virus. And they started to mix more like they usually do when they are sailing. And then the epidemic started, as you can see here. And out of 1,568 sailors, 70% of them got infected. And that tells you basically that in a place where you mix like you would on a ship like this one, Well, you do reach the herd immunity before the epidemic stops. And the seasonal coronavirus, for instance, did not play much a role. The immunities that some may have got being in contact with others that got infected first also did not play much a role. And when it comes to this story of homogeneous mixing, clearly 70% would be the figure that you reach. And as I said, some models that have been worked since do suggest that eventually, if you have some very highly susceptible people that get infected first, or if, for instance, the older people do not mix socially as much as the younger people, you may decrease your 67% to something like 50%, but probably not much lower. The children, the data are a little bit complex here. What we all agree with is to say that they develop mild disease. It's very rare that children do a severe disease. There are some indications that they are less susceptible to infection, but it's a bit controversial. When you look at the viral load in their throats, clearly they have the same viral load than adults, so they should be as contagious. However, when you look at the data, and particularly among children less than 12 years of age, it seems that the virus doesn't spread as easily from children of that age to others or to the adults. That could be eventually because they are less symptomatic, and because they are less symptomatic, they don't cough, and therefore they are not as contagious. Now let's move to history and what is happening. How do you reach herd immunity naturally? Naturally is what has happened with those pandemic flus. You know, we had 100 years ago the Spanish flu, and then we had 3 other pandemics, the last one being in 2009. And what did we learn from those pandemic flus? Well, you do have several waves. You don't reach that herd immunity in one go. And for the pandemic flu, the first wave started in the summer and then was followed by another one in autumn and then in the winter. The first one actually did not kill that much. The case fatality rate was 0.35%. But the second wave, the autumn one, as you can see here with the death, did kill more, 2.3%. And the third one was sort of in between. But as you can see, there has been several waves, and there have been some control measures taken for the Spanish flu. That was less the case for the 2009 pandemic, where fortunately the virus was not that dangerous. And there have been also several waves. Here you have New York, where you can see the first wave was in the spring and the second one in the autumn and winter. And if you look at the United Kingdom, you have 3 waves. First one is the summer 2009, second one in the autumn, and then you have to wait for the winter 2010 to see the third wave. So these are 3 cumulative waves before you can reach for pandemic flu, the herd immunity, and it becomes completely seasonal. And as you can see, season makes an effect, but probably not the first year when nobody is immune, when you do have some circulation of the virus, despite the fact that you are in the summer. But later on, it becomes seasonal, like all of respiratory virus. When it's cold, people are inside, and those viruses are more easily transmitted indoors. So what do we need to control the viral circulation? And this is the way I'm going to end this talk. As we have understood, for the SARS coronavirus, there are currently 2 pillars for controlling the epidemic, which have been used in Asia, particularly with success. You need to have those barrier measures that you all know. I mean, we have a physical distance of 1 meter, you wash hands, you clean the surfaces, you wear masks, and you try to be careful with the confined environment, because clearly it is there that you have the largest clusters. Then you need to test, trace, and isolate. And the testing so far has been done with those tubes that you put in your nose, which are a bit uncomfortable, and get your results after 2 days. What I hope for this autumn of 2020 is that we will soon have salivary test, which gives you results in less than 1 hour, and that much more convenient because it's not as unpleasant, I would say, than getting this nose test. And we may eventually also use those smartphone apps which tell you whether you have been in contact with somebody who got infected. Currently, they don't work that well. Matter of how to parameterize them, but well, I mean, maybe with some progress, they could be very useful for the tracing. And we need to target the super spreading events and to prevent them. What we have learned during this first wave of the COVID-19 pandemic is that the clusters took place in confined environments such as bars, cruise ships, disco, meatpacking plants, workers' dormitories, churches, nursing homes, confined environments that we have to really make a very clear surveillance there, eventually close some of them, and avoid the large gathering of people. This is the best way to control the viral circulation until we get what we need most at this stage, which are drugs and vaccine. Drugs, because we would be able to prevent the severe forms of disease, and that's what we want to avoid. We have made some progress with the anticoagulating drugs, like the heparin-like of drugs, with these corticosteroids. I mean, they have been proven effective if they are given at the time you start to develop the complications. Also, the way you ventilate patients now has become much more effective than the beginning and help with high flow of oxygen to avoid the intubation. And we hope that during the autumn or early January, we will get some new drugs based on interferon, maybe anti-cytokines, monoclonal antibodies, we don't know yet. And vaccines, which would be the safest way to reach herd immunity without going through the complications of disease and the death. The vaccines, currently, there are 6 which are in phase 3 trials, which mean that they are currently tried against placebo to see if they protect against the infection. We hope that by 2021, we will have safe vaccines, that's a priority, and partially effective. If they are more than 50% effective, it's a good beginning. And that is the only way to reach herd immunity. We cannot allow the virus to circulate freely. That is too costly in human lives. And if you move to a lockdown, it's too costly for the economics. But if you can wait for the drugs to prevent the complications and the vaccines to reach herd immunity through vaccines, then we eventually would have finally got control of that terrible virus. Thank you very much for your attention.